Well, thank you very much. It's always a pleasure to come back to Egypt, and particularly to Alexandria, where I was here a few years ago. So thank you for inviting me. My title is a little different. It's a little bit larger, expanded. How we treat it, what we do when our surgeons have not been initially successful. So we're looking at something rather more rare than the very common diseases you've seen earlier, like diabetes, kidney disease, and cardiac disease, but one which I find is of overlasting and everlasting interest. So I'm basing this very much on our own publications, plus two sets of guidelines produced by the Endocrine Society and the Pituitary Society. So it's an overall consensus opinion, rather than being very much isolated to myself. So I think it's very important when you see your patient with Cushing syndrome, first of all, to treat them purely from a metabolic point of view. These are patients who are sick, who are ill. Now obviously you're going to do a lot of investigations and tests, but it's very important that you certainly become immediately aware of their hypertension, their diabetes, and I'll spend a little bit about antibiotic prophylaxis, normal, and increasingly we're considering anticoagulation. Some of what I'm going to say is also summarized in this nice paper by Maria Treserio. But in terms of infection, remember when patients present with Cushing syndrome, they're immunosuppressed, they will often have very high levels of cortisol. And in this nice paper from the NIH, they looked at patients who became extremely unwell with sepsis and those who did not. And in essence, if you have a level of cortisol, now we use nanomoles per litre, around about 40 micrograms per deciliter, that's the level at which sepsis is an increasing risk and at which you might want to consider prophylaxis. So, by emergency treatment, and I think this is important, we must make the patient well in order to investigate them, is treat hypokalemia, often with spironolactone, control the blood pressure with standard treatment. Hypoglycemia, you may need to give an insulin infusion to lower it. If they're psychotic, it makes life difficult. We have antipsychotic agents. As I said, beware of infection, particularly pneumocystis. And if you've got very high cortisol levels, I would go straight to the combination of trimethoprim and cotrimoxazole. And increasingly, we anticoagulate. I anticoagulate the patient right at the start with subcutaneous heparin. Then, at that stage, you can then consider whether you want to investigate in detail, or if they're really unwell, you may want to lower the cortisol, improve metabolic states, and then go back to do your full investigations. Routinely, I do not use blockade unless the patient is either very sick or is going to be delayed in terms of their definitive treatment and surgery. So, the definitive treatment is surgery. I'm glad we have a number of pituitary surgeons here, because this is the most important initial part. And the reason is that if you look at the long-term mortality in Cushing's disease, only if the first operation, the pituitary operation, is successful, can you actually normalize mortality. So it really is vital to A, make a diagnosis, and B, once you've done that, get the most effective surgeon to lower up the cortisol and cure them. And how do you actually cure them? What you say is cure remission. Well, ideally, the post-operative cortisol in the first 2 or 3 days should be less than 1.8 micrograms per deciliter. If it's in the low range, less than 5, then probably keep an eye on it and repeat it. In about 1 in 20 patients, 5%, this fall in cortisol may be delayed over a month. This usually within the first few days. Once you've achieved that, then you have to, at least in the short term, put the patient on replacement therapy, and sometimes it's worth using a high dose to begin with in order to make the patient feel well, because you're going from a very high level to a low level. And then over the next 2 to 3 to 4 months, you can gradually lower the dose. Now, the treatment of choice is transfemoral surgery. This is quite an old series, but we were able to look at a mean of about 15 years following the operation. So the initial cure rate actually was only about 60%, although nowadays the cure rate should be at least 80%, if not higher than that. The problem is you're still left with a small number who are not cured, and also with a high rate of recurrence. So overall, even in the best centres, you will have about 25% of patients who either have persisting Cushing's disease or who later recur, and it may be 5, 10, or even 15 years later. That really is rather a problem. Now, how can you predict recurrence? Well, it's difficult, but if the normal axis recovers certainly less than 6 months, it makes it very likely that they are going to recur. Very large tumours, high levels of ACTH, make it more likely to recur. In our study, if anybody did not show recovery of their axis in 3 years, then we found recurrence was very unlikely. But it's still there and it's maintained over a long period of time. So what do you do then? You've found the best surgeon, you've operated on your patient, and they have persisting disease. Well, first, be absolutely sure. Could this be ectopic ACTH? You see that in about 10% of ACTH-dependent Cushing syndrome. So reconsider the diagnosis, have a look at the pathology. Talk to the surgeon. Did he see a tumour? Was there possible pathology? Are they absolutely certain? And maybe the centre, and maybe you should bring them to a more specialist centre for their next operation. And if you do that, around about 50 or slightly more percent can be cured the second time around. You might go back and try again for a selective adenectomy, go to hemipene hypophysectomy, or maybe in the older patient, total hypophysectomy, as long as you're certain of the diagnosis. And that will then pick up a number of uncured patients. If that still fails to be effective, then you do have radiotherapy, and then obviously you know various types of radiotherapy. The standard one we've used over very many years, 25 fractionated external beam radiotherapy. We know the risks. Obviously, over time, there'll be hyperpituitarism, a slightly increased risk of cerebrovascular disease, and second tumors, which I'll come to. We have a more focused radiotherapy, gamma knife, cyber knife, usually a single dose, and there's also proton beam available in some centres. But I think the bottom line is that the effects of radiotherapy are independent of the type of radiotherapy given. It's dependent on the type of tumour. So, fractionated external beam, as I said, it may take quite a few years. They say 2 years, but in many cases it could be 5 years or longer. So you've got to have less time when they're not controlled. Recently, Nikki Karabataki in Birmingham had looked at second tumours, which was always a worry, and she found that in unirradiated patients, there was a risk of about 2% of meningiomas, gliomas, astrocytomas, and it was slightly increased to 4% in patients who had radiotherapy, but the majority of these were quite benign. So although there's a risk, if you keep the 45 gray in small fractions, it's a very small risk. Radiosurgery, it's fine if you have a small tumour, well delineated, at least 5 or 6 millimeters from the optic chiasm. In this particular case, you'll see the normalization rate at 2 years or thereabouts was about half the patients. So I think in general, do not use radiosurgery because you think it's better in terms of the rate of onset or the hyperpituitarism, but it is more focused and it's a single dose and it's more convenient. But it's not necessarily better. Similarly, the great vogue now is proton beam therapy, but there's actually very few data on proton beam in the treatment of pituitary tumours. This is quite an old paper now, as you'll see. The single publication, 33 patients, quite a small number, and look, a about the same rate of normalization at 1 to 2 years, the same rate pretty well of pituitary deficiencies. So is there an advantage if you can afford $100 million to buy this machine? Well, the Russians did publish some data many years ago. I can't find anything recent on that. But I did look at a paper on craniopharyngiomas, which was published in The Lancet, and which I wrote a brief editorial. And the interesting thing is that for these complex tumours, the side effects, the rate of onset of control, the tumour shrinkage was exactly the same with proton beam therapy. Maybe there were fewer cognitive defects. So if you don't have it available, I don't think you should lose any sleep about that. Okay, so we've got the non-cured patient. We've thought about radiotherapy. Why use medical therapy? Well, obviously, I've mentioned already the very sick patient. You will treat them immediately for hours or days. If you're delaying surgery, you may want to pre-treat them for a few months. But most commonly we use medical therapy is if we want to avoid radiotherapy or we're awaiting for the effects to occur, which, as I've said, may be several years. And we have a whole variety of different drugs which work at different parts of the steroid pathway. Mitotain really should only be used for adrenal cortical carcinoma. These drugs, mifepristone and recoronant, can block the glucocorticoid receptor, and I'm really not going to spend any time on them. They're not particularly useful. So we'll just speak on these two classes, the ones which block high up in the pathway and the ones that block 11-hydroxylation. Now, metyrapone we've been using for 30, 40 years. This is a big series from the whole of the UK with my colleague John Newell Price. And you'll see overall, if you have metyrapone, you'll get great improvement in around about 80% of patients. Just be aware, though, that, and I think, as I mentioned before when I was talking about aldosteronism, assays are important. What are you measuring? How are you measuring it? In this paper from Peter Traynor, it looks as though the cortisol is coming down quite nicely using your conventional assay. But when you use mass spectrometry, it's gone down quite significantly. And the reason is that most immunoassays or enzyme immunoassays will measure 11-deoxycortisol. So when you're using metyrapone, and as I'll show you, cylindrostat or etomidate, anything that blocks 11-hydroxylation will increase the precursor and will influence your assay. So you really must be aware of that. Ketoconazole, though, works very proximally in the pathway. Does that work? Well, again, a paper from Castanetti in Italy, that regardless of the cause of Cushing's syndrome, it normalizes cortisol in 50% of patients. It's relatively easy to use, it's relatively cheap. You do have to check liver function tests, but it's quite nice because it lowers all of the cortisol metabolites and therefore does not give rise to any major precursors. Now, somebody had a wonderful idea and said that the major problem with ketoconazole was liver toxicity. So as there are two enantiomers, two optical isomers, maybe the one that is less effective on the liver, the L isomer, levoketoconazole, will be less likely to give you liver damage, but the same effect. But in fact, the published data, although it works in lowering cortisol, the published data suggests that the response rate was maybe not quite so high, and you still had some patients with abnormal liver function tests. So this new drug, which is not generally available, I suspect, is not going to be particularly helpful or useful. Something that may be more useful is osilodrostat, which is very similar to metyrapone, blocks 11-hydroxylation, and in a whole number of trials have been very effective at lowering cortisol in Cushing's disease and, in fact, in all forms of Cushing's syndrome. And here in the first trial, it's 80% control, really very effective. Dr. Tabaran has pointed out, though, the levels may be quite variable over time, so you will need to follow the patient very carefully, as the levels may be fluctuant. And again, you need to have an assay that will measure this very accurately, like GCMS. In the longer term, this is a double-blind randomized trial. This was open label for 36 weeks. You found again a very high rate of control, and then this will then follow by looking at the clinical responses, and equally, if you lower the cortisol, you've got very good control of the clinical responses which parallel the fall in cortisol. So osilodrostat is a nice drug. It's very easy to use. It's easier in some ways than the Thyroid, but it does have one very important drawback. It is very, very expensive. But it does work, again, long term, up to 2 years, 72% control. I would just like to spend a couple of minutes talking about another drug which also blocks 11-hydroxylation, but you can use it intravenously, and it works almost immediately. So etomidate, which the anaesthetist introduced many years ago, blocks 11-hydroxylation. You can infuse it. And here we have a patient from Liverpool in the north of England. She's a young woman who had extremely high levels of cortisol. That would be around about 120 micrograms per deciliter. Very sick woman, infused her, cortisol came down, but again, if you use gas chromatography, you'll actually see a slightly lower level. But a very useful drug to get you out of trouble very quickly indeed. So beware of the assay, but when you have a really sick patient, control the metabolic state, and follow that, if necessary, by intravenous etomidate, normalize the cortisol, and then you're in a position to start thinking about how you're going to treat the patient long term. But I think this drug, although rarely required, can save the patient's life. For example, I've referred this patient at the Royal Free Hospital in London. They rang me up and said she's 54. She, in this case, is not Cushing's disease. It's a pancreatic neuroendocrine tumour. They could not easily treat her, and they suddenly found, although they were thinking of peptide receptor radionuclide therapy, that her cortisol was massively increased. Here we have a scan showing metastatic tumour, and she also has a small Troisier node, as you might expect. And we immediately put her on intensive care, infused etomidate, normalized her cortisol. It actually went down really low, carried out bilateral adrenalectomy, undetected cortisol. So therefore we were able to now put her in a position where we had cured her ectopic ACTH and could continue with treatment for her metastatic tumour. So overall, looking at a recent review, centrally acting drugs for Cushing's disease I haven't really spent much time on. They're occasionally useful, but it's adrenolitics, adrenostatic drugs that are most useful. And I think most people should be able to get hold of Thyroid. Ketoconazole is also in common use. But what happens in the situation where either you're not giving radiotherapy or you still need to cure the patient and you've not been able to, as in the patient I showed just now with ectopic ACTH? Then you are still left with adrenalectomy. And I'd like to spend the last 10 minutes just talking about the advantages and disadvantages of adrenalectomy. Now, a study 10 years ago from the Munich group, they showed that all their patients with Cushing's disease, well, surprisingly maybe, about 1 in 5, 20% or so, actually ended up with bilateral adrenalectomy. Is that a good treatment? With mortality very low, residual adrenals very low, the median stay was only 5 days, but now with increasing laparoscopic adrenalectomy, the patient only needs to be in hospital for 1 or 2 days. Nelson syndrome, I'll talk about in just a moment. It's just quite interesting. We don't really use the term Nelson's now. We really talk about an expanding pituitary tumour post-adrenalectomy. And just to show you, this was the original paper published by Don Nelson back in 1958, I think that was, when he was in Boston, and he then went back to Salt Lake City, where he spent the rest of his life. But I looked into this for an editorial, and interestingly, Don Nelson was a very honest man, and he actually said in this article in the New England Journal, you know, another patient was reported just like this in London. So I looked up the patient in London, and I'm pleased to say it was reported from my old hospital, St. Bartholomew's. So maybe it shouldn't really be Nelson syndrome, but I think we'll keep the name. Okay, we have a problem. You take out the adrenals, and the problem is either you give too little adrenal, or you give too much. So you're sailing between these two difficult situations. And we know that in Addison disease, even in Scandinavia with very high level of medical care, there's an increased mortality in patients who have been adrenalectomized or have no effective adrenals. But equally, we know that if you give more than 20 milligrams of hydrocortisone a day, that will give you an increased waist-hip ratio, an increased metabolic risk. So if you give too little, you're at risk of high mortality or adrenal crisis. You give too much, you're at the risk of a metabolic syndrome. Now, there is one way you might get on with that. There is a modified release hydrocortisone that you give just once a day that does give you a better metabolic profile. So here's one study which showed that when you switch from ordinary, immediate-release hydrocortisone to the once daily, you can improve metabolic parameters and quality of life. And similarly, we carried out a study at the University of Warwick where we put patients in a sealed room to look at their oxygen consumption, and also found that once daily modified release hydrocortisone improved metabolic parameters generally. However, you may say, well, that's also very expensive, but my colleague at Imperial College in London has said, actually, if you have somebody who's adrenalectomized, you can simply use prednisolone once a day, and that will give you a once daily treatment with normalization of the metabolic profile rather than the rather more expensive treatments. So once daily prednisolone, which is very easily available, inexpensive, is a cheap and simple form of replacement therapy. And I think when drugs are not available, it's something that should be borne in mind. The normal dose for an adrenalectomized normal weight patient is 4 milligrams each morning. But to go back then to this whole question of, is it safe to carry out bilateral adrenalectomy? Well, it is actually quite common. This is a very recent paper which shows, in this case, 39% of patients who were not cured by pituitary surgery ended up having adrenalectomy and steroid replacement. And what they were looking at is patients who are long-term medical treatment, and the medical treatment over time gradually decreased. Some required repeat surgery, some were on long-term medication, but 39%, that's not too, more than a third, nearly a half, actually required bilateral adrenalectomy. And we shouldn't forget, however much we like playing with our drugs and optimizing their treatment, Cushing syndrome, Cushing disease, is a lethal disease. It's a horrible, disfiguring, ugly disease, and if you can actually cure it instantly by bilateral adrenalectomy, and it's safe to do, we should seriously consider that. There is risk of Nelson syndrome in this. The Opricin is a big pan-European study base, so they've now got 1,564 patients, 1,000 with Cushing's disease, and of those who had bilateral adrenalectomy, about half showed an expanding pituitary tumour, Nelson's if you wish, of which half only could be controlled. So that really means that you do need to be fully aware that the patient may develop an expanding tumour and it may be difficult to treat. So, really, just think about what do we do with Cushing's disease. Well, the treatment of choice is obviously transformative surgery, microadrenalectomy with preservation of pituitary function. If that is not curative, make sure you've got the right diagnosis and then get a second operation considered. If that is still ineffective, then you have a number of options. 2 major ways to consider it. Bilateral immediate cure, 1 to 2 days in a hospital. Probably the increased mortality is due to the doses of hydrocortisone replacement being a bit too high. There is a risk of Nelson syndrome or progressive enlargement of the pituitary tumour you need to be aware of, and therefore you will need to follow that patient lifelong, both in terms of their steroid replacement, hydrocortisone or fluorocortisone or prednisolone, and you need regular assessment of their MRI and plasma ACTH. The alternative is some form of possible lifelong medication. Now, if you use radiotherapy, that may just be for a few years of treatment. But there may be a prolonged delay. There is a risk of hyperpituitarism, cerebrovascular disease, and second tumors. Some people I've spoken to are now thinking about long-term treatment, even without radiotherapy, simply using medical therapy. For example, at a meeting last week in Stockholm suggested that if the patient has failed surgery on 2 occasions, treat them with oscillostat forever. But really, I think that's, for most of us, impractical and really very expensive. But I think these are the 2 major options long-term. Radiotherapy with interim medical treatment or bilateral adrenalectomy. And you have to be able to consider each one on an individual basis with your patient. And indeed, in the group's textbook of endocrinology, which is most of you know is one of the major textbooks, Anton Tabaran, I think is a real expert in this area, emphasizes that bilateral is a treatment of choice if they're not cured by pituitary surgery in a young woman in whom you don't want to use drugs in case they're teratogenic, and you don't want to irradiate in case she becomes gonadotrophin deficient. But even long-term, in other patients, it should still be considered, although in many cases it's rather late in the day when we use that. And just one last rather exciting new treatment. I know radionuclides are not much in use in this country. They are actually extraordinarily helpful. And when I was in Oxford, we had this patient with a surgeon that failed to find a tumour. So I sent the patient to Cambridge for what's called a C11 methionine scan. It showed that the tumour was actually to the right of the fossa. The surgeon went back, reoperated and removed the tumour. And even more useful, in India they're now using radiolabeled CRH. In a paper in JCM, they identified the tumour beautifully with this radiolabeled CRH, and now that CRH is not easily available, they're using radiolabeled desmopressin to identify the tumour. So I think the future will be very much in terms of radionuclide identification of these patients. But don't worry if things aren't going so well. Even in North America, we're in the best places, and these are the centres who actually gave data. God knows what it's like if they didn't give data, but at a median follow-up of 2 years in this study, about a third of patients were not well controlled. So I think we can do better, we will do better, but we just need to try harder. So final comments, you see the patient, treat the metabolic and acute problems, You may need to lower the cortisol. We have drugs that can do that. Make sure you have the right diagnosis. Get the best transsphenoidal surgery you can find. If the surgery fails, think again, is it the right diagnosis? Maybe they should be reoperated. And you have different types of radiotherapy, and we have different types of medical therapy. But if all else fails, bilateral adrenalectomy will cure the Cushing syndrome. And that's really what we're aiming for in this sort of patient. We're going from this horrible disease to the patient who looks and feels well and is cured, and hopefully will remain permanently in remission. So thank you very much for your time today. Do you want to take it?
I have a good question. Because there are several papers stating that patient really cured by calculating clinically from Cushing, they still have a high cardiovascular mortality. Do you want to comment on that one, please?
So the question is, patients are cured, cortisol's normal, everything looks fine, but first of all, they still seem to have high risk factors for cardiometabolic disease, and actually, as well, they often do never quite go back to normal. Now, I think this is what one might call hysteresis, a maintained effect of steroids on the metabolic and cerebral profile, which are poorly reversible. We don't understand why. It should be you stop the steroids, everything goes away, but it doesn't. So that's why I think these patients, apart from recurrence, require lifelong follow-up for hypertension, hyperlipidemia, obesity, and generally not feeling very well. I think anyone who's looked after Cushing's patients long term knows that these are sometimes not very happy patients with persisting risk factors. I don't know why, but they are there. But one point which I didn't show, my colleague Marta Corbedes at Barts Hospital has shown that, interestingly, many of the metabolic effects of corticosteroids can be antagonized by metformin. So I very quickly go in with a diet metformin if they have a metabolic syndrome. But it's a good point, I don't know why.
What's your recommendation when you recommend going for a second surgery and when you recommend going to medical therapy?
So the question is, when the patient is apparently cured in remission, everybody's very happy, then 2 years, 3 years, 10 years later, the disease comes back. And I think that's very much an individualized basis. Obviously, the first thing we will do is image the pituitary. And if we can clearly see a tumor, we often can, then the choice between transsphenoidal surgery and often radiosurgery. And then we have a joint meeting with the surgeon and a radiotherapist and come to a decision. There's not a right or wrong. Very often, if the surgeon is happy and the patient has few comorbidities, the surgeon will go back in again. And that seems if the patient is happy. If I'm not too sure, we think we can see the tumor or the surgeon is not comfortable with reoperating that fossa, then we would focus on radiosurgery, which I have used and has been effective.
And does the age of the patient affect your decision to use radiosurgery or any type?
Yeah, I think age and the general conditions. A young woman who is concerned about her reproductive life, I think that will make you consider the decision. For example, surgery versus radiosurgery. Surgery, if you were to be rendered erythropoietin deficient, would be unfortunate. With radiotherapy, that may also happen, but will be delayed. So if she's planning on extending her family immediately, then you might say, okay, let's go for radiosurgery. If there's no need for further reproduction or fertility, then transsphenoidal surgery might be the preferred choice.
My question, is regarding the
every 3 months to begin with. And again, the problem is, They had recovery of their access. They do a 9x cortisol, 4 morning dose. That seemed to have recovered. You do a synaptin test, all looks normal. Then the patient seems happy. Oh, this is great, this is my normal pituitary. But the problem is, it's probably a recurrence of the tumor. Now, the question then arises, and I think this is a big problem in endocrinology. The pain, how do you actually know when you should start intervening again? Do you do it on the morning cortisol, on the urinary free cortisol, on the late night salivary cortisol, or how the patient feels? And the answer is, we don't know. So I see the patients every 3 months to begin with. Once they've shown recovery of their axis, maybe every 6 months. But it's often the patient who comes back and will tell you, I think my disease has returned. But even if they show early recovery, if the patient is otherwise feeling well and you're treating any comorbidities like hypercholesterolemia, I'm fairly relaxed about simply watching them over time. And it's only when the patient then says, it's coming back, I know it is, doctor, then I become more concerned. So every 3 months to begin with, then every 6 months, when they show recovery, absolutely fine. And most of them know that if they're not well, they're not feeling well, they'll ring the nurse in the hospital and we'll bring it back earlier.
The second question is about those patients who do not respond to pre-surgery. Those patients who have not too much choices in Egypt, we have no medical drugs for the treatment of pushing. Actually, the only available drug is Cabergoline. Do you have good experience with Cabergoline in the management of Cabergoline?
Oh, lovely. Sorry, yeah. I didn't show, I mentioned the stereotyping Cabergoline. The stereotype, don't worry if you haven't got it, but it's pretty, I don't use it, I don't like it. It only works in about a small number of marked cases. I will try Cabergoline, particularly in a young woman who's got persisting disease who wishes fertility. And about a third of patients, 30 to 40%, will respond to Cabergoline. It's as you know, a cheap drug, easy to use, safe to use. So yeah, I will use Cabergoline in the first instance. If there's still a problem and it's a question of reproduction, then I'll go to bilateral adrenectomy. But the odd thing is that with Cabergoline, even if they do respond, a certain number then relapse on the Cabergoline. I don't understand. But it's certainly worth a try.
Professor Croce, thank you for your excellent presentation. So the most assuring sign of successful surgery was to find why very low cortisol level. So sometimes after surgery, you may be confronted with, say for instance, a serum cortisol of 7 our units nanograms, so I guess it would be around 190 in your unit something. So most probably this patient is having a persistent disease. So do you think we need to intervene at this point, taking into account the literature that some patients may show late response to recovery? I mean that they are showing good response, but at a later point.
That's a good point. In fact, on the flight over here, I was going through all that all over again. And I think most people think if it's less than 2, you're cured. And if it's more than 5 micrograms per deciliter, but it's within the normal range, you might simply want to watch. But surprisingly, that patient almost certainly still has tumor. But it may be another 5 years before it becomes clinically important. So, yeah, somewhere between 5 and 10, I would simply watch and wait. I wouldn't immediately jump in. If the cortisol gone back to where it was when they started, then maybe I think it's easier for the surgeon to go in the first 2 or 3 weeks when there's still a nice little tunnel to go up there. But I wouldn't necessarily panic if it's 5, 6, or 7. I think you have time. And about 1 in 20 will actually still show a gradual fall over the next 3 to 4 weeks.
So my question is, sometimes post-surgery, the neurosurgeon, they do advocate to give the patient a sort of steroids as an anti-inflammatory measures, and this may mask the immediate picture. Because our success to have a low cortisol and to improve my patient, the longer you are going to be on replacement, the better the outcome afterwards. So how am I going to solve this situation? The surgeon, the neurosurgeon, they did start the steroids. I don't have the facility to test my patient. So what I'm going to do?
Well, as I said, I want to start from here. I think we had this problem when I was in Oxford. The endocrine unit was in one place and the neurosurgical unit was in another. But we had our endocrinologists who would go over there. So I really think this is very close collaboration with the surgeon. You and he or she makes the decision, watches the patient closely. I think I told you the story that a pituitary surgeon who's now retired told me he would go in the morning after the operation and say, how are you feeling? And the patient would say, I feel absolutely terrible. And he said, it's wonderful, I've cured you. So, but obviously, leaving a patient with no cortisol is slightly risky, so you need very good endocrine and nursing cover. And agree a protocol with your neurosurgeon. This is what we do, this is what you do. So, I'm not arguing with each other.
Okay. I will go to the other side. It was a successful operation with lot of cortisol. What sort of cortisol you prefer, and for how long, and what are the lab tests follow-up?
Okay, so I would take the cortisol. Very often, the neurosurgeon insists on steroid cover with the pre-medication. But that, the half-life is only a few hours. So day 1, day 2, I would leave off steroids and measure the cortisol. Then 2, 3, 4, and then very quickly, as long as you have close supervision by the nurses and doctors, you can decide where they're going to go. So I do a 9-day cortisol.
For how long? For gradual was
Oh, well, I think that by day 2 or 3, if it's less than 2, then you're home and dry. You put more steroid replacement. If it's 10, 15, then repeat it, but it's almost certainly persisting disease. And if it's that horrible in between 3, 4, 6, 7, then I would just simply repeat it over time and watch the patient carefully. I think sometimes you don't have to give steroid replacement. Even if the patient goes home, you can give them a steroid card and warn them about the treatment crisis, but not necessarily give them full steroid cover. And then you can just really wait for 2 months and then bring them back and reassess.
Thanks a lot for this elegant presentation. My question about the ectopic ACTH the ectopic human will fail to memorize it. How can you proceed ectopic ACTH and we fail to memorize this ectopic? How can you proceed at the medical or bilateral?
Okay, well, it's a whole nother lecture on ectopic ACTH. But in brief, if you have diagnosed ectopic ACTH, obviously if you identify the tumour, you remove the tumour. If you can't identify the tumour, then you either treat medically for a short while or you proceed to bilateral granulation. All patients with ectopic ACTH, we want to be sure we do petrosine sampling. Okay?
It's difficult to read the form.
Okay, so you have a patient, it's judgment. If the patient has a short history, very severe Cushing's, an ACTH of 300 or 400, then you image, chest, If you can see it on the CT, that's fine. If you can't see it on the CT, we would do radionuclide imaging. If you do not have radionuclide imaging, but you think it's ectopic ACTH, I would do a bilateral granulectomy.
Even if it is ACTH level.
Even
when it is ACTH level at the development of Nelson.
I think so. I mean, I published a young woman, she came to see me, she was 25. She clearly had ACTH Cushing syndrome. We did petrosine samplings and it's not the pituitary. All the imaging was negative. So we took out her rings. And that was 30 years ago. We haven't found a tumor, I don't think, although she did have a small appendice or carcinoid. But, she's got married, she's had children, she's got divorce, she's gone through normal things in life, and we've cured her Cushing's. So, what I want to emphasize in my whole talk is that Cushing's is a horrible disease. And if you had to, take the adrenals out and then get rid of the disease. Obviously, if you still think it might be pituitary, you've got to keep imaging. But you're going to have to do that anyway, as there are hypotheses in place.
Is there any difference, long-acting or short-acting corticoid coverage? They have what's pituitary adrenal axis?
Well, that's an interesting point. You mean, if somebody, I think somebody asked me that a while ago, and I checked, and I don't think we know. I think the argument is that if you have short-acting steroids, that may allow the pituitary to recover that much faster. But the answer is we don't know. Most of my patients, if they're cured, they simply go on 3 times daily hydrocortisone with the last dose at 1 o'clock in the evening. And that allows overnight their ACTH to increase.
Have you seen cases with Addisonian crisis after a few days following surgery for Cushing's?
So, have I seen an adrenal crisis after surgery for Cushing's? No, I think probably because we just monitor these patients very closely. A crisis means that you haven't been looking after the patient closely enough. I think an adrenal crisis is a failure of medical care. So if you look at the patient closely, you're watching them closely, nurses are all aware, and it's a nursing task, how the patient is doing, then you might see the patient feel a little nauseous maybe, then you check the cortisol, and if in doubt, do a blood sample and give a steroid. But I've not seen anyone in a serious condition.
Professor, thank you for the presentation. As a neurosurgeon, I want to ask you a little question. In the series of transphenodal surgery, there are all cases with a seen lesion in the radiological investigation before the surgery, the failures, or did some cases include some patients without a seen lesion?
Yes, I think you're quite right. You are less likely to get a cure, a remission, if there's no obvious lesion beforehand. These cases, if there's no obvious lesions, we almost always do bilateral tapered sampling. That to some extent would help lateralize it. The patient I showed, there was a man, the petrosine sampling said, well, we think it's mainly on the right. The surgeon didn't actually see it, but when we told him again because of the nuclear scan, it's definitely on the right. Then he went back and found it. So yeah, the imaging, if it's negative, does make it more difficult to cure the patient.
So as a recommendation, you still recommend that
Yes.
you go to transphenodal surgery?
Yes.
In spite of not having the lesion?
Yeah, in spite of not imaging the lesion. We published some last years of children with Cushing's disease. Now, can you imagine you have a child that big with a pituitary which is tiny? So the MRI is almost always negative. So what we would do in those cases is do petrosine sampling. If you don't obviously see the tumor, do hemihypoxectomy on the side of the petrosine sampling. But yeah, these are hard cases.
And the results are different than in the cases
Yes,
where
yeah.
you see the lesion.
Yeah, the success rate is low. Yeah, absolutely.
I guess everybody is getting advantage of your presence among us. The question will be endless, so we can continue that later on in coffee break. But thank you very much Professor Ashley for your nice presentation.